We'll now move on to the next session. I request Dr. Felix Jebasing to moderate the session on global inequity and its impact on diabetes, its influence on clinical presentation, and what are the solutions, by Dr. Nihal Thomas.
Warm good afternoon to everyone. And now the next talk will be on equity and diabetes, which will be delivered by Professor Nihal Thomas, who is he's a senior professor in the Department of Endocrinology, Diabetes and Metabolism, and he was a vice principal for research, and he was a former HOD of endocrinology, and he has multiple publication of more than over 350. So he's saying to say no because he is my teacher as well. So now he is my colleague. So with that, over to Dr.
Thank you, Felix, and I'd like to congratulate the Department of Medicine, including Professor Anand Zakra and the other people who have actually played a major aspect. I think it's a really visionary thing to have this sort of a meeting which has blended various specialties of medicine and look at what is really contextual from an Indian perspective over here in areas of need. So this is what I'll be talking about, a little bit about the epidemiology, defining and understanding the role of global inequity in diabetes, the aspect of lean diabetes, malnutrition modulated diabetes, a condition which has raised much discussion, a lot of controversy, and of course is now on its way towards being re-recognized, and how this whole thing can be blended into malnutrition and global inequity and structural racism. So I'm going to be moving from epidemiology, a bit of pathogenesis, some clinical aspects, and then looking at it from a philosophical perspective as well. So this is a slide which is taken from the IDF Atlas and shows you the prevalence of diabetes. It's about 4 years old and shows you the various regions in the world in terms of the number of patients with diabetes. And of course, the South Asian zone where we are located is anticipated to have an increase. And from the more recent publications, perhaps even more than this, the areas to be watched, of course, Africa, and of course, the Middle East, which has the highest density of patients with diabetes, and places like Qatar, where 90% of people above the age of 75 years of age actually have diabetes as well. One of the most striking things, and of course, sadly enough, it is true right across the world. I'm not sure about the accuracy of the map, but definitely in India, about 40 to 50% of patients who have type 2 diabetes do not know that they have diabetes in the initial phase of their lives. And particularly, if you look at Afghanistan, I can accept it. Interestingly, Poland also shows up as black over there in addition. So when we talk about the epidemic, we have an epidemic within an epidemic, and that is hyperglycemia and pregnancy. And I won't have much time to actually allude on this, but I'd just like to make one very, very strong statement. Right across the board, when we treat diseases which are emerging, there is a very strong industry background behind everything. And you will look at many guidelines and you will hear about the need of insulin and its appropriateness in treating diabetes in pregnancy, that is gestational diabetes. But I would also like to say that there is enough evidence to show that metformin can be used quite safely in gestational diabetes, and even in patients wherein metformin has been started before pregnancy, in patients with polycystic ovarian disease, in vitro fertilization, and obesity. There's collated data to show that it's safe enough. And like the previous speaker, and like what Dr. Leena had said, something is better than nothing and will do a lot of good for the community. So metformin from the 24th week onwards, absolutely no doubts, and is reasonably safe in the first 2 trimesters of pregnancy as well. So the more recent publication in Lancet shows that the number of patients is even more pressing, and we are close to probably 100 million in this country at this point of time. I'm inclined to believe that this is correct, because with the galloping numbers that we see in our outpatients everywhere, it's really true. What the recent Lancet article has also focused on is that there are other risk factors for diabetes which we should strongly recognize. So we have to take into account a lot of other things which are very much present in our country, like ambient particulate air pollution, household air pollution, which is there in home cooking modules, wherein you have smoke from firewood and coal, secondhand smoking, which is also very important, and high alcohol usage. Besides this, the dietary factors have now been categorized very clearly, and we have enough evidence to show that diet low in fruits. And there's a big difference between fruit juice and fruits. Fruits per se are healthy. Fruit juice, take the fiber away, are not good. So diet low in vegetables, diet low in whole grains. All this seems to be common sense, but it's now, there's enough evidence and a publication, or at least 2 or 3 on them in each of these situations. And coming down to the very obvious of lower physical activity, high air temperature, and with global warming, this is going to become an issue, and low air temperature, as in this air-conditioned auditorium, wherein there are lack of fluctuations in temperature and your body gets acclimatized and you don't burn enough energy. So this is a slide which I always talk about because I like it so much when you talk about diet. And we know that an apple a day keeps the doctor away. But if you look at this slide, and if you can see the dots and the triangles, besides the ones which are colored, which are not supposed to be there, are that on the left-hand side, you can see on the right-hand side, you can see food which is healthy, like fish and greens and strawberries and stuff like that, which are very expensive. And then you go to the right and you look at the top over there and you have oil and margarine and sugar, which are not expensive. And you have exemptions on GST, etc., which make them cheaper. And so therefore, good food is expensive, and food which is not that good but tastes good is actually much cheaper. And of course, we talked about the governments. You heard Dr. Sheshadri talking about the rationing of food. In almost every state in India, we have rice and other forms of food grains which are given at low cost, and we need to have a mindset. It's a publication from several countries across the world, which looked at Salim Yusuf actually spearheaded this article on consumption of diet. Now, if you look at that hazard ratio, you may be less than impressed in saying it's only 1.2. But to do a big study like that and collate data, 1.2 is actually, I think, pretty much significant. And you come to 1.6 when you talk about South Asia. And the paradigm shift in the quality of what we're eating in terms of cereal to what we are taking here in rice is perhaps not the best of things that happens. So can we go back to millets? Is asking the question again, which was raised over there in the other auditorium. Definitely, it is feasible, cultivable in less arable land, less dependent on irrigation. Disadvantages, you have to have a major change in the government distribution policy. And of course, reorienting the farmers towards millet cultivation away from rice, improving consumer awareness and acceptability of this whole thing. So, but I think this is a very, very important step when it comes to, I would say, amongst the top 3 things that should be looked at if you want to target prophylaxis of diabetes and obesity. This is some data from Velo, and a number of people have contributed to the Velo birth cohort over the year. Anthony Swami, who was the statistician running this cohort, and his predecessor, Dr. Sundarrao. And what a number of studies have actually come out of this. But this is actually true incidence data showing the prevalence of diabetes in rural and urban India. And this is Velo. Rural is the KB Kuppam block, and urban in Kaspa Ramnaikapalam area, wherein you can see that there's a blurring of the prevalence of diabetes between rural areas and urban areas. It's almost the same. So we are reaching that point where the epidemic is kind of ubiquitous right across all borders. This is once again data taken about 15 years ago from Velo in schools, and that we found at that time in 2008 that 20% of males had a fasting glucose of more than 100. And we did this again in another school, and we found that the waist circumference and the other parameters in the mother strongly correlated with that of the metabolic syndrome in the child. And if both parents had the metabolic syndrome, the risk was 6 times greater in the in the child. So this is all about learned behavior and customizing people to change their behavior as a family unit. Once again, which is something which is mentioned in the other auditorium. So how shall we define global equity? And these are the social determinants of health, which have been talked about right across for the last 3 days. which I won't go into too much, but there are aspects of economy, awareness, presence of healthcare access, and the social community context is important. These are two publications which me and my colleagues came out with in the middle of June last year, which talk about global inequity. And when we define global inequity, we talk about aspects of inequity which basically look at the social and economic aspects. And then we come into two terminologies. One is something called structural racism, wherein societies, it's not as such racism in terms of the race that we are thinking about, but differences in the community per se lead to social biases. And if you think back to wherever you're working, these biases are always present in the system and may lead to differences in healthcare, which may also be there. Geographical inequity, and a combination of structural racism and geographical inequity is defined as structural inequity. So this is something which we need to target if we want to make a holistic change in healthcare behavior right across the country. Now, here's an example of very strong structural racism. And this is published in a Nature journal back in a couple of years ago, which has shown that the average height of an Asian Indian did not increase for about 150 years. Whereas in Europe at the same time, there was a 14 centimeter gain in height across in Europe. And after independence, the average height of an Indian increased by 5 centimeters. So there are obviously nutritional things which are present at that point of time in addition. Now, here are examples of structural inequity in relation to diabetes. Very low income country like sub-Saharan Africa, the expectancy of a patient with type 1 diabetes would be 13 years. This is something which we used to see in probably even Velo 40 years ago when we didn't have glucometer strips and we were running around trying to manage diabetic ketoacidosis in the ward with urine sugars repeatedly rather than with glucose. And we have come a long way since then, but we still have distance to go. We have schemes which can provide glucometers and strips for poorer type 1 patients. And I think even the Tamil Nadu government has now taken on an initiative from that perspective. A high income country, on the other hand, would be 65 years. That's a strong example of structural inequity. In a country like the United States, and we know the discrepancies in health which are there, maternal mortality is huge difference between that for Native American Indians versus the other Americans as well. And so also as we look at the proportion of type 2 diabetes in Indians. So the global inequity in diabetes we are showing over here is that the increase will be in low income countries much more than the high income countries, and the potential factors which we have to target, and this is the checklist that we need to target if you really want to bring things down from a public health perspective. So screening is important, but it has to be done on a global basis, not just through camps. Trying to centralize the glycemic control, reducing hypoglycemia and hyperglycemia with appropriate medications, and trying to cut down the complications of diabetes on a long-term basis. So minorities in many countries are going to be affected much more than the majorities when it comes to diabetes. And this is also a feature of structural inequity. Now I'm just going to switch to lean diabetes. And I heard, I was just talking to Yogesh about an hour back on this huge number of patients who are very lean. And when I say lean, I mean BMI less than 18.5, not the lean which WHO says BMI less than 25 or Indian says less than 23.5, but really skinny people who are less than 18.5 kg per meter squared. And we come across a particular phenotype which is very different. Before I talk about that, I will also talk about type 1 diabetes, of course, being the commonest, and we call it in adults slowly evolving immune-mediated diabetes. This is a study from the Community Health Department, spearheaded by Kurian and Anu, and showing you that lean people with diabetes are around 0.3 to 0.6%, depending where you're looking at around Velo. And the commonest is still type 1. There's no doubt about it in these urban and rural areas here. I'm not going to say that is true necessarily in rural Chhattisgarh or Orissa. We really need to know the numbers to understand it, but it still should be looked at there. And one condition, these are the list of conditions which we think about when we think about lean diabetes. I shall drop out lipodystrophy, which is in fact, even from my perspective, an uncommon condition. I will also not talk about HIV lipodystrophy. It is very complex in its own way. But very briefly about these 4 conditions over here. And this is what is possible in a limited resource setting. You certainly can take a good pedigree chart, detailed history, physical examination. And if your pedigree is strongly positive, it is unlikely to be type 1. It is unlikely to be malnutrition modulated diabetes, and also less likely to be fibrocalcic pancreatic diabetes. So there are certain familial types you think about, and you would think about the MODIs or the monogenic types. The very basic test, if you're at least in a suburban area where you have access, are the GAD antibodies to rule out type 1. It's still very, very important to rule out type 1. And if you can do a C-peptide, you can send that off to another center, you can do. Fibrocalcic pancreatic diabetes can be missed even in a place like CMC-Velo in almost 40 or 50% of cases. The ultrasound of the pancreas can be very subjective, and there's a problem there. So ideally you need a CT, and I know that is a problem sometimes in a resource poor area, but it is very important to rule out type 1 and fibrocalcic pancreatic diabetes. So this is a classical patient, and the CT shows this intraductal calcification, unlike alcoholic pancreatitis, low BMI, and what we use for malabsorption now is the stool elastase levels. And this is a disorder which occurs mainly in tropical parts of the world. Some of the features, they have a very high energy expenditure. So they have low birth weight due to uncontrolled sugars, due to malabsorption of fat, and also high energy expenditure, and that is driven by the mitochondria through paradoxical rise in glucagon levels in these patients. The other features are they have autonomic dysfunction, which is very common due to malnutrition and poor glycemic control. They have micronutrient deficiency, and they have a significant proportion of osteoporosis as well, which is related to fat malabsorption. Now, this is data from Lucknow STPGI and my good friend Dr. Ish Bhatia, and we did the genetics lab did the genetics for this. And in his group of less than 35-year-olds, 15% had fibrocalcic pancreatic diabetes. It's about a decade back, and these proportions keep changing, but that is actually quite large. 60% did not have abdominal symptoms. That means they didn't have abdominal pain, nor did they have steatorrhea. So it's important to think about this condition, even if they do not have abdominal symptoms. Next, I'll talk about the monogenic disorders, and of course, the classical forms of monogenic disorders, which occur in autosomal dominant conditions, even seen in pregnant women. But I shall talk about conditions which may mimic fibrocalcic pancreatic diabetes. They can have a borderline small pancreas, but they could have an autosomal dominant inheritance pattern, and certain forms of MODI, one type called MODI5, maturity onset diabetes 5, can also present like this, and can even have diabetic ketoacidosis at the same time. They're antibody negative. So if you have DKA, diabetic ketoacidosis, it may not be type 1. These are inherited forms. You could have other causes. If you don't have DKA, you could still think of type 1. That's the other paradox that you have to know. I was just mentioning now that about in the older patients, more than 15 years, 75 to 80%, because they're being picked up early, do not have diabetic ketoacidosis at presentation. So that is important for you to understand about type 1 diabetes. Here's another one, 20-year-old male, and with recurrent lower respiratory tract infections, malabsorption, and also has an atrophic pancreas, pretty obvious over there, the fat replacing the pancreas and prominent splenic vein. And this is actually cystic fibrosis. It's another condition which you should be thinking about. People would have thought about 20, 30 years ago, this condition does not exist in India. It is there. And my colleagues in pediatric pulmonology also see a fair amount of it amongst children in addition. Another one, and we always think about this DID mode or Wolfram syndrome, but there are people who come without the optic atrophy changes. They may have some diabetes insipidus, as seen by that. And this is a family member who had a more florid presentation with deafness, seizures, as well as optic atrophy with diabetes. Now, it's important to make this diagnosis because there are specific therapies available. If you pick these up early and they have only diabetes, you can use agents like valproate, which are not expensive, to prevent the progression to other neurological features that these patients have. So this is a publication which came out a year back, showing that by and large they need insulin. And what is more striking with the more recent data, if you look here very carefully, is that the black dots are the age of onset of diabetes. But the other dots are the complications, as you can see, optic atrophy, deafness, which occur much later. So at the cross-sectional time point, you would have not thought that this is something else. You would have thought this is type 1 diabetes. But if they're antibody negative, you need to realize that you could be dealing with something else. And that is the role. Now, the cost of these genetic testing is becoming lower and lower as time goes by. And of course, we have grants which can cover for this as well. And I think it's important we look at this across the country. And using valproate in these patients may delay the other neurological problems which can occur in these patients. Finally, coming to this condition, the perplexing malnutrition modulated diabetes, severe, so-called severe because the fasting glucose levels are more than 200 as reported by Tripathi and Samal way back in the 1960s initially, and onset of diabetes before 30 years of age, but generally more than 15 years of age. Leanness, absence of ketosis, even if you stop insulin for 20 days, there's no ketoacidosis, and they are of impoverished background, and they seem to require more insulin in those days. And you rule out all the other causes of diabetes over here. Like I mentioned to you, you need to rule out the other causes. But it was unceremoniously dispatched from the WHO classification in 1998, saying because there is no physiological basis for this. These are type 2s are poorly controlled. They have some other diseases like, say, tuberculosis or malabsorption, and that is why it does not really exist. But more recently, there have been publications from Ethiopia, from Uganda, which have been talking about this condition more. It's not as common here in Tamil Nadu, but I do believe from central India, it is quite common and seen with greater frequency. So we did a physiological study, which took a very long time with our collaborators from the Albert Einstein in New York. And I'll just summarize what we found physiologically. These are the tests which we did, which involves the gold standard for insulin resistance, indirect calorimetry for energy expenditure, spectroscopy, and hepatic glucose output from the liver. All this is important to characterize it physiologically. Otherwise, no one on the international front from a physiological perspective is going to believe what we are saying. And we had to tightly control the sugars with insulin infusions for a couple of days. So basically this condition is a very distinct entity. There's no autoimmune or standard genetic. We did the entire MODI screening of 60 genes plus insulin resistance genes. The BMI is far lower with BMIs less than 18.5, which is a characteristic. And they have low fat content in the liver, which is not like type 2 diabetes. The hepatic glucose output is also quite low, and which is not like type 2 diabetes. So this is not lean type 2. People keep talking and saying it's lean. It is not lean type 2. It is not type 1. And they have this habit of eating less protein. For what reason, we really don't know. So now the other thing, the good news is, and this may be because we tackled the glycotoxicity by giving lots of insulin infusions to bring the sugars down before the physiology, is that 50% respond to oral anti-diabetic agents. So maybe you need to give insulin to start with, get the sugars down, and then give them OADs and see what happens. And this is an area which we are really intrigued with, and we need to research more. Maybe it's an epigenetic change to the beta cell membrane, which works, and that's why the OADs seem to work, and the dietary protein intake as well. So we're just kind of reclassify this, and we're just trying very hard to get it back on the WHO classification. We've knocked off severe diabetes. We've knocked out insulin requirement. I'm not saying that these aren't apples and oranges, and whether we're dealing with more than one type of lean diabetes, who knows, we could. But this is what we think it is characterized by now. Very briefly, in those 5 minutes, which I hope I can expand by 1 minute if possible. So there are historical impact of social determinants of health, which are very important. And I talked about the height difference between the Europeans and Asian Indians between 1830 and 1950. These are factors which have made a difference. And the Bengal famine in the 1940s, which was very artificially created disorder, social disorder, which also would have led to umpteen number of malnourished mothers who had low birth weight babies as well. And this is the result of maldistribution of food across different states in the country. So things like that. And like, for example, in the Second World War in Netherlands, which is now one of the richest countries in Europe, where when the Nazis invaded, they were cut down to their calories to 400 calories a day for many, and during pregnancy. So you can imagine the low birth weight babies at that time. And 30 years later, those low birth weight babies, the so-called Dutch hunger winter, had a much higher prevalence of diabetes, hypertension, and obesity. So this is the Barker hypothesis, and I won't allude to it more, but intranatal malnutrition leads to low birth weight babies. So the intranatal malnutrition also leads to a smaller pancreas, multiple other uh, biochemical defects on the tissues, diffuse glucose transporter issues on the muscle, increased peripheral fat, percentage body fat is much higher, and this all collates together to form a diabetogenic milor. We're not proud to say that we have a very high prevalence of undernutrition in India. Whatever we say we have done in the last 70 years, we still do have about 15 to 20% malnutrition, and we still have the highest prevalence of low birth weight in the world as well. We've tried to physiologically look at this a few years back, and this is done in the Chad cohort with Kurian and Venkat and the others, where we did basic science studies again. They're shorter, lighter, had a reduced muscle mass, increased diastolic blood pressure, and reduced bone mineral content, but they were lean. The BMI is only 18.5 or 19 at the age of 20. And so they had not yet developed insulin resistance, but they had a higher percentage of body fat in their bodies. When we put them on a bicycle and made them exercise, we found that they improved in muscle mass. So it's good that they improved in the fat-free mass came down, and the energy expenditure improved. So that's good news. And we did an assessment after 6 months. We did an assessment after 1 year, and we found that they'd all sold their bicycles. So that's a social issue, which public health needs to handle maybe better than I can. But now coming to the bottom line, why does it happen? And from animal studies, the beta cell mass is low. If you induce a state of intranatal malnutrition, follow it up with postnatal malnutrition, the beta cell mass in these animals is lower, and they have what is called micro islets as opposed to the macro islets in greater proportion. And that is one of the reasons why, not all of the reasons, but one of the reasons why they may be having insulinopenic state. So just a summary, the common things you should think about, the social determinants which I've talked about, and the importance of intranatal and postnatal malnutrition, which may lead to a very different disorder in this country. I'd like to thank our various funding agencies and all my colleagues in the department who have helped out. Thank you so much.
Thank you, sir, for the wonderful talk. And we have few questions. First question is, you already mentioned about the famine in India. I mean, there's a question on that. Is there any association between famine happened in India in early 1900s to current diabetic epidemic?
So probably yes. There are patches in the country, and perhaps even the southern parts of Tamil Nadu and Kerala, which had a lot of epidemics and various food insecurity issues way back in the early 1900s and late 1800s. There was a big plague epidemic in this zone between Kerala and Tamil Nadu from 1890 till 1915, I think, if I'm not mistaken. Some of the more senior people like Dr. Serra, who might be here, might be able to allude to that. Not that I'm saying you were born in 1900, but even then, perhaps with your experience, you might know. Right. So, but I'm sure those would have led to, way back in the early 1960s, Dr. Jacob Ebran used to see a lot of young strokes with hypertension. And the Barker hypothesis is also responsible for low birth weight and an increased prevalence of hypertension. In the Rishi Valley cohort, they've shown a very high prevalence of hypertension in addition. And that is also a group where malnutrition is much more and much, maybe even prevalent till about 10 to 15 years ago in a big number. So definitely the GFR, the kidney, goes down with intranatal malnutrition, and subsequently hypertension prevalence is also greater.
There are a few more questions. I hope we have time. Yeah. Does structural casteism play any role in the pathogenesis of diabetes, especially malnutrition modulated diabetes or lean diabetes, any higher prevalence noted?
I don't know the answer to that question. It's a very difficult one to answer, and it's a highly sensitive area, which I personally would find great difficulty doing research in. Now, we know that people who are underprivileged and peripheralized will have all these factors, right? We do expect that them to have perhaps more malnutrition at times. But food availability is not an issue. So I think there'll be a shifting paradigm in the next 10 to 20 years, provided there's no other major national catastrophe of any sort which might occur. That's the only thing. So I think maybe you would like to comment on that, Mr.
I had two comments, and the first is, I understand that you discuss the malnutrition related diabetes, or call it lean diabetes, at an individual level. If I take a community angle to community, and communities, lens to it, the role of famines, multiple famines over time, through the colonial period, has been hypothesized to cause epigenetic changes.
Yes.
Across communities, and thus, a large proportion of Indians getting, or other South Asians getting, this so-called epidemic of diabetes, of which, in certain communities like in central India, it would be a large, not a minor proportion, maybe 30% or 1/3 of people with diabetes would be having this. And that needs to be, and to fix the, the other structural inequality correlates like, caste and geographies would be important to do. I think as while we study the phenotype, and so that's one point that I wanted to say. And second, this was a discussion that has been happening in the last 2 days here about democratic knowledge production. And in this case, in this diabetes, the discourse on diabetes in this country exemplifies how this inequity in how this knowledge production is so biased. We are told that we are a diabetes capital in this the country as a whole, or South Asia as an area. But the fact is, the discussion about diabetes is the suggestion that come out is that we should eat less, exercise more, and do yoga. And the entire idea is that we probably have a lot of type 2.
Yeah.
And I think the request, especially to someone like you and then CMC along with, is to get this right knowledge across about the diversity of the diabetes that we see and its pattern, and to speak up for the people who have suffered structural inequity, and in that sense, our casteist, or I would call it our Indian form of racism over the years.
Very true. So, in fact, the moment that this diabetes care article got published, within a couple of months, we had a rebuttal from my esteemed colleagues who also are endocrinologists, saying this condition doesn't exist. Not quite. Well, they kind of accepted the physiology, but they said that, are you really sure if you read those articles? And this is what, it's a different kind of racism, I suppose, where you think that only people who have a certain BMI should have a particular problem, which is not true. And even I was just telling him that now you have this cluster differentiation of type 2 diabetes, where they've given, it's very iffy, but they have one condition called SIDD, severe insulin dependent diabetes. And so the opponents to our article said it is a form of SIDD. But if you look at the Indian SIDD BMIs, they're all from urban areas, and their median BMI is 23.5. Now, I don't know what is SIDD about it, but I was just telling him, you give names to certain things so that the industry can jump onto it and ride that bicycle. Severe insulin deficient diabetes. Yeah.
Do we have time to go for one more question? Yeah. I think I'll club the question together. Is there any studies available on gut microbiomes and low BMI diabetes?
No, not specifically about low BMI diabetes that I know of. In malnourished people, of course, there are studies ongoing on gut microbiome. The change in gut microbiome certainly might be responsible in part for some of the aspects of diabetes as well. But in fact, even we know that perhaps the change in the gut microbiome may even be a stimulus for beta cell function as well. So there are studies to suggest that this may be a function. Now, it may be one of those factors which may be important. We don't know the real answer to that.
Thank you, sir, for
Thank you so much. Thank you.
enlightening us with your knowledge on diabetes and inequality.
I request Dr. Felix to present the memento to Dr. Nihal. We'll be now moving on to the next session. There is a short break with refreshments available outside, and the next session will be in Hall A, and it will be relayed here in Hall B.